ovarian torsion or just testicular torsion, you always want to use the color Doppler first. Bring your scale all the way down to the lowest sensitivity if you can. And if that's not, you're not getting any blood flow, then still use a power Doppler, because power Doppler is more sensitive than color Doppler, meaning it's going to be more likely to pick up that blood flow. Okay. But you can clearly see here, guys, or in your book, you can see that veins are supposed to be anechoic on the inside, but you can see here where it has this thrombus right here, this complex blood clot right there, and you can see it kind of continuing throughout. So that would be Mondor disease, which is just basically a blood clot in the veins of the breast. Okay, typically involving these three veins right here. So, guys, that's galactoseals, sebaceous cyst, mastitis, abscess, and now Mondor disease. Let's talk about a hematoma. Hematoma, of course, guys. Hema meaning blood. It's a blood-filled mass with bruising or skin thickening. Right. The appearance is variable based on the amount of liquefaction and clotted blood present. Okay. The longer because the appearance is going to be different, because the longer you have one, the thicker the blood is going to get. Okay. Color Doppler confirms the absence of blood flow, and the pseudoaneurysm may develop after a biopsy. Meaning that after a biopsy, after they try to, get a sample from it, they may, you'll see like color Doppler near the walls of this hematoma. Okay, what's left of it. A seroma is an accumulation of serum that can collect within the surgical cavity or biopsy site, and afebrile with possible pain, and shape of the surgical cavity, low-level echoes, posterior enhancement, and absent blood flow. A seroma. Shape of the surgical cavity, meaning that if they insert a needle in there, then that seroma, or that fluid may accumulate in that same pathway that they inserted the needle in. Here's what we have right here, guys, a hematoma. You see these a lot, and you can see that these are really low-level echoes right here, and this whole thing is filled with blood, meaning that you won't see that leveling off because the whole cyst consists of a hematoma. It's filled with blood. Okay? Guys, also, don't forget to use these. You see how they have on the ultrasound image this body marker? Don't forget to use those body markers when you're scanning. Okay? Because these are very important as far as letting the doctor know exactly where you're scanning. Everybody knows where the body markers are on IU-22s or wherever you're doing your machine.
On the
Epic.
Get it?
Huh?
I'm on you get it.
You know how to pull it up? It should be on the top right. It should be a button like on the top right. I think it's on the second row, the first from the third from the left and the right. Okay. So use those. Just like you see those body marks right there, you have another one right here. This image right here, guys, remember I said after biopsy, you're prone to having a pseudoaneurysm. And this is what a pseudoaneurysm look like. You're gonna have these what's it called?
Twinkle?
Not twinkle. It's you're gonna have all of these colors mixed up together. I forget what these are. No, it's not called twinkle. It has a term for it.
Oh, but is it twinkle? Is that the one they call it twinkle or twinkles?
It's not the comic tail.
Nah, it's not that. It is. I want to say it's aliasing, but it's something else. I forget what it's called. Actually. It's in physics. We'll talk about it in hemodynamics, but it leaves me right now. But yeah, that's what a pseudoaneurysm would look like after biopsy. Okay. And final, and fat necrosis. Fat necrosis inflammatory and ischemic process consequence of blunt trauma, surgery, radiotherapy, and inflammation. So we have this is actually the mammogram right here, guys, and this is the ultrasound. Okay. The trauma disrupts blood supply, leading to necrosis. Of course, that's what necrosis is, meaning that the tissue is dying, correct? Not getting the blood supply and the oxygen it needs. Okay? Traumatized fat turns into lip-filled cyst or fibrous sclerotic mass. It has a variable appearance sonographically. Oil cyst encompassed by thick or thin wall. Fat fluid level, mixed echo pattern, mural nodule, variable enhancement, rim calcification possible. Guys, as far as the appearance goes, you know, I'm telling you guys, I don't know how much I'm gonna have. I may have some of them, but I'm not gonna have you memorize every single appearance. Okay? Most importantly, I want you to know, you know, the definition. What exactly is fat necrosis? You know, what is a Mondor cyst? What is a sebaceous cyst? Okay? And we have a post-surgical scar caused by connective tissue proliferation. You'll see this like, it'll be a rise on the skin, right? If you have a it'll be above the skin level. Okay? Mammographically, it's going to be radial dense. Sonographically, it's going to be irregular hypoechoic area with acoustic shadowing or architectural distortion, no longer Doppler signal. Okay? And whenever you have like a scar or anything like that, you'll always kind of see this that shadowing posterior to it. I think because of the you know, I don't want to say it may or may not be some kind of hardware or staple there, but also with just the scar tissue not being able to penetrate that scar tissue. Okay? And you have a skin thickening and retraction is going to be common. Okay? And guys, I'll give you guys 5 minutes before we get into the solid breast masses. So 8:05. You know, if I see my people getting tired. 9 breast masses. So 80% of biopsies are benign. Solid masses are assigned risk using our BI-RADS characteristics. benign tumors, they displace tissue rather than invade tissue, and they're normally well circumscribed and have gentle macrolobulation. Malignants, they are invasive into the tissues and they're indistinct. And here's some characteristics of some benign features. They're going to be oval, have macrolobulation. They're wider than tall. That's very important right there. They're wider than tall. And they have thin echogenic pseudocapsule. Here's a list of our benign solid breast masses. Again, when it comes to benign pathology, there's so much more benign pathology than malignant pathology. So, first one is going to be fibroadenoma. We're going to talk about an adenoma, phyllodes tumor, or phylloids tumor, a hemartoma. Guys, don't get that confused with a hematoma, right? A lipoma, intraductal papilloma, intracystic papilloma, and papillomatosis. So, a fibroadenoma, guys, it's the most common benign solid tumor. Fibroadenoma is the most common benign solid tumor. Okay? It affects women 15 to 35 years old, maybe single or multiple, and may affect both breasts. Okay? Non-tender, smooth lobular, firm, rubbery, and movable mass. Mammography is going to show water density, world circumscribed, oval, and round mass. See, it's very well defined, even on the mammogram. Okay. Sonographically, the same thing is going to be well circumscribed, oval, homogeneous, a solid mass. Doppler often shows vascularity. Fibroadenoma, the most common benign solid tumor. Less. An adenoma, less common than a fibroadenoma, is primarily composed of the glandular elements in the mammary layer. Okay? Secretory adenomas are present during pregnancy and lactation. sonography is chosen over mammography because the patient is pregnant or lactating, meaning they don't want to give that person radiation. And you don't want to give a pregnant person radiation. Internal areas of increased echogenicity. Some fluid-filled slits. See little slits and probably some fluid right there within this whole mass right here. Prominent vascularity, isoechoic and hypoechoic, well circumscribed, enhanced transmission, and may grow large and regress after lactation ceases. Adenoma, not as common as fibroadenomas. Made of the glandular elements and usually comes during pregnancy or lactation. Phyllodes tumor is a rare fibrothelial new growth with a leaf-shaped growth pattern. It's unilateral and can grow very big. It is the most common breast sarcoma. I know we're still talking about benign tumors, right? Most of the time, these phylloid tumors, they are benign. However, they can undergo a malignant transformation. It's the most common breast sarcoma, phylloid tumor. It has potential to spread, and treatment includes wide local incision or a total mastectomy. It is discrete, non-tender, mobile, and may bulge or stretch the skin. Mammogram is going to be radiopaque, oval, polylobulated, and sonographically is going to appear similar to a fibroadenoma.
Where's the leaf shape pattern?
I don't see it very well here. I remember some images I looked up that you can see it a lot better. You see it a lot better.
Like it's shaped like a leaf, or it's just got like the
Just kind of like has those like
the veins?
yeah, like those veins. Those veins are going to be those fluid-filled slits. Again, I use the pictures from the book. You guys, those are the pictures you guys are going to be able to see. So I want to use those instead of finding new pictures that you guys can see. A hematoma. It has varying amounts of normal and dysplastic fibrous epithelial and fatty breast tissue, generally unilateral, greater than 3 centimeters. It's painless, soft, and rubbery. On mammo, it's a mixed radiolucent and radiodense areas. So that means sonography is going to also have a mixed echo pattern as well. It's compressed the surrounding tissue. Okay, again, benign tumors, they displace rather than invade tissues. And here goes an image of a hematoma right here. See how it has both cystic and solid components. Okay. Mostly solid. Image of a hematoma right there. Okay. And a lipoma, I'm sure you guys probably see this, pretty often. You see these on, I know at LBJ they do lipomas on almost everybody. Not necessarily just in the breast, but just in general. Anybody that comes in there for a non-vascular exam is usually a lipoma. So lipomas appear very similar no matter what tissue you're doing. Okay? So lipoma, of course, is just fat tissue or adipose. It is slow growing, 2 to 10 centimeters. One thing about lipomas is that if you have one, you probably have them in other places as well. You probably just don't know or feel them yet. But sometimes if you scan somebody and they have a lipoma, you can also scan other areas that's near that area and find other lipomas that are maybe smaller than the main one you see. Okay?
So, you had a guy come in once and he had like a whole bunch all over his body. But the tech only measured you only measured like the 3 biggest ones?
The biggest 3. Anytime you do anything on ultrasound, it's always going to be the largest 3. So yeah, that's why I say anything. I don't care if it's massive, I don't care if it's cyst, thyroid, testicle, no matter where it is, renal, you only measure the largest 3, so don't be overwhelmed by, oh my gosh, I can't, it has so much stuff going on, I can't make it out.
Is that by the book? Is that by the book? Because yesterday we had a renal, what was the saying? You should say measure like the big ones, but if you want, you can also measure the little one, and measure from different areas of the organ.
Yeah, I would like that. That's why I say the largest three. It's kind of like the standard. I'm gonna if they're just three huge ones, I'm gonna measure like that. But if it's just three and they're all over the place, I'm gonna take a superior, mid, and inferior lobe
Yeah,
system.
you should.
Because that's the thing, you get caught up in the breast, in those cysts, and you may be able to determine them on your scan. But when somebody, remember, it's all about trying to have that repetition.